Good afternoon. My name is Johnny Mahlangu. I am a hematologist based at Charlotte Maxeke Johannesburg Academic Hospital. Welcome to this webinar today. We are going to talk about gene therapy in hemophilia, specifically introducing the adeno-associated viral vector transfer, and to review some of the data that we have with regard to gene therapy to date. It is an exciting time, and certainly you could ask the question as to why is gene therapy so important? It is important for a number of reasons. First of all, most of us grew in the era of standard half-life clotting factor replacement, which is characterized by troughs and peaks, and of course pharmacokinetic that would not allow us to be able to institute prophylaxis adequately. This was followed by the extended half-life products, which really led the way for us to be able to elevate the trough level to be able to protect individuals from breakthrough bleeds. And that also reduced the treatment bleeding as well as the treatment burden associated with prophylaxis. We've moved on to non-factor therapy. Its effect is not measured by the factor level, but by the rebalancing of hemostasis such that the patients are able to protect themselves against bleeding. And of course, the latest innovation is the gene therapy. With the gene therapy, we are expecting a steady factor level, almost the same as one would expect in a normal individual. And that is the excitement about the gene therapy, is that we are trying to normalize the production of clotting factor to the level that is expected to be in a normal individual. Just a review of the science behind the gene therapy. All of us obviously are much familiar with the clotting factor. The genes associated with those are what we are interested in when we do gene therapy. The DNA from the various genes are then packaged into the vector, and the most commonly used vector is the adeno-associated virus vector. And of course, we are expecting over time that other vectors may well become available, such as the lentivirus vector. Once the transgene together with the vector have now been packaged together, they are then infused in a peripheral vein into a patient that requires gene therapy. And upon infusion, the gene then is transported via the bloodstream. These particular vectors have been modified to be liver-tropic. So the gene gets into the liver cells, but it sits episomally. It does not integrate. And of course, when it is in the episomal environment inside the liver cell, it will then start to produce factor as one would expect in any individual if you are giving the correct gene. And that is the science behind the gene therapy. We are absolutely excited about this unprecedented evolution of the gene therapy. We've seen a large number of these programs in the last couple of years. Not less than 7 such programs have now been put into the mainstream clinical trials. Most of these will tend to use adeno-associated virus as the vector. There's no doubt in my mind that over time we will start to see other vectors such as the lentivirus, which has already been started at least in one of these programs. Whereas hemophilia B gene therapy was the very first, we are seeing now the acceleration of the gene therapy for hemophilia A. The hemophilia A gene therapies are now at various stages of development, with at least one program showing the program having progressed to phase 3. The majority of the programs are still in phase 1, phase 2. The Hemophilia B program, which was the leader in the gene therapy in hemophilia, is also progressing very nicely with a large number of players, and there are a number of programs that are now in phase 3, in addition to some that are already in phase 1 or phase 2. And of course, we are not completely new into the era of gene therapy. We've had a large number of publications largely describing the preclinical settings. And more recently, we've seen the results of the phase 1, phase 2 being published in very high impact journals. We've had at least 3 publications of Hemophilia B gene therapy, and 1 publication on Hemophilia A gene therapy in the recent past. What I would like to do is then to give an overview of the results of these publications in the context of gene therapy as to where we are, and in fact what have been the safety, efficacy, and other characteristics of these programs.
Select the correct statement about the patient population studied in published AAV-mediated gene therapy clinical trials for hemophilia.
And I'll start off with the populations that participated in the gene therapy programs. Across the 4 published studies, the majority of the patients, of course, would have been the adult patients that are 18 years and above. But the bulk of these patients were actually between the ages of 30 and 50. 54% of them were actually mature individuals that would wanted to make a difference. There is a smaller number of patients between the ages of 18 and 30, about 38%. And what is exciting for us is that with the progression of the gene therapy over time, we do expect to enroll in the future adolescent, and certainly we hope that gene therapy will be safe enough to be instituted in the pediatric group. Very small number of patients that were over the age of 50, about 10% in this cohort of the published studies. If one looks at the baseline characteristics of the patients, by and large, the majority of them had severe disease, whether it was hemophilia A or B. The level of the factor was less than 1%. There were 1 or 2 patients that were included that had moderate disease, particularly in the Nathwani study. There was 1 patient. In the George study, there were 4 patients. And in the Misbach study, there was 1 patient that were moderate in level. And the importance here is for us, obviously, to understand what the impact of gene therapy would be across the spectrum of our patients with hemophilia. If one looks at the prior therapy that the patients had, not unexpectedly, the majority of the patients were on prophylaxis, with a small number of patients on episodic treatment, as one would expect in this day and age. What about the genotype? The majority of the patients, as expected, in fact, had the common genotypes, the missense mutations and the deletions, with the inversion occurring in some of the patients, and only 1 patient, in fact, had a splice site mutation. So the genotype is actually typical of the population of patients we look after.
Efficacy outcomes from ongoing AAV-mediated gene therapy clinical trials for hemophilia include:
So what were the results of some of these programs that have already been published? And I'll try and summarize here at a very high level. One clearly can see that almost all the patients benefited from the gene therapy. The lowest level of the factor achieved with each of the program was certainly above the baseline of most of the patients, which is less than 1%. And of course, the highest level achieved was variable depending on the program. For example, in the Nathwani study, patients' factor 9 level went as high as 10%. In the George study, as high as 60%. In the Misfach study, it went as high as 10%. And of course, the highest level was achieved in the factor VIII gene therapy, the Rangarajan study, where the highest level recorded was 237. Perhaps note here, I'm not talking about the peaks and troughs. I'm talking about overall the levels of factor that was seen across the program. The bleed rates when the patients were post-gene therapy was much, much less compared to the baseline mean annualized bleeding rate before gene therapy. If one looks at the overall reduction in bleed rate, it ranged from 70% in the factor IX study of Misfach to 96% in the George study, clearly indicating the impact of gene therapy in the bleed rates in this patient population. If one looks at the usage of the replacement therapy post-gene therapy, it almost mirrors the reduction in the bleed rates. We're talking about over 90% reduction in the factor usage across all the programs we've seen to date. What I want to show now is perhaps the individual studies, and not so much detail, but just to look at the trends that we are seeing. First of all, I want to show you the SPARK 001 study in which the patients received 5E11 vector genome per kilogram dose. You'll see that, in fact, there was much variability in the factor level that was expressed in the various patient population. The lowest in this cohort was 14%, and the highest was 81%, with a range of patients achieving various factor levels in between. Perhaps notably is that all of these patients received the same dose, 5E11, despite the fact that the factor level was very, very variable. And perhaps the second note here is that there seemed to be some consistency in the expression, at least in the period that we're looking at, which is up to a year for some of these patients. The expression seemed to be holding and certainly has some element of durability. A different study, the BMN 276E13 vector genome, was the dose that was given to the patients. And this particular study, we are seeing the same variability of factor expression of factor VIII. But what we also note is that there are some patients that had gone very high as in above the normal reference range of 150 units percent. There are some patients, in fact, that seem to be coming down overall. We obviously are very concerned about that trend, and we hope that, in fact, the level will remain at least above a hemostatic level that will allow the patients to be protected from bleeds. What are some of the sort of summary outcomes that one can gather from these studies? Clearly, at least in the currently published data, it would seem that there is an element of sustained therapeutic factor expression in most of the patients. We can also say that there is a reduction in the bleed rates that the patients experience when they are compared to the pre-gene therapy era. We obviously expect that if they are bleeding less, they will use less exogenous replacement factor, which is the case in this particular summary. Of course, the most important aspect of gene therapy is the safety. What are some of the safety characteristics of the gene therapy programs? I can give a very brief summary here. We have not seen any gene therapy related serious adverse events. In other words, no patients have died or required an admission as a consequence of the gene therapy being administered. Once the patients have started to express the factor level, none have developed inhibitors, which is good news. As we know, managing inhibitors is actually a very complicated and expensive business. There were no deaths to date in the current gene therapy programs. If one were to summarize the adverse events across the programs, it would seem that, in fact, at least in some of the patients, infections seem to be one of the commoner occurring adverse events. The frequency of occurrence was 6 patients in the Anathwani study, there were 9 patients in the George study, and there were 3 patients who developed fever. Strictly speaking, that is actually not infection, but nevertheless, one would assume that the fevers are related to an underlying infection that may well not have been identified. And perhaps the most important thing is, what was the severity of the adverse events? If we're to summarize, the majority of the adverse events were either grade 1 or grade 2 in severity, with very few patients. In fact, 1 patient across the programs that had grade 4 adverse event, indicating again that the safety profile of this published gene therapy program seemed to be acceptable and something that we're obviously very pleased about. The one thing that is clearly something that we expected when the gene therapy started is the development of the inflammation of the liver, the transaminitis. And this is a summary of the transaminitis that were picked up during the course of the published studies. I'll start off, in fact, by indicating that the management of the transaminitis is with steroids. And in fact, all the programs to date have used the steroids in the management of the transaminitis. The number of patients across the programs have been very variable, from only 2 patients in the George study to as high as 7 patients in the Factor VIII program, the Rangarajan study. If one looks at the number of patients that did not receive steroids, you'll see that, in fact, it was in the majority, at least in this cohort of published studies. If one were to summarize the data here, it would seem that the data suggests that there is some poor correlation or inconsistency between the development of transaminitis and the endogenous factor level. In other words, there seemed to be no correlation between the loss of expression and the development of the transaminitis in these patients. And of course, the question that we'll all be asking ourselves now that we have begun the journey of gene therapy in the community is, what are the patient's expectations and perceptions of gene therapy? It obviously depends on where you live and whether you do or do not have access to current therapy. I would like to believe that gene therapy is holding a lot of promise for our patients. In some patients, it is regarded as a one and done. In other words, it's something that they do once and forget about. It has the promise of rebalancing hemostasis and bringing hemostasis into a steady state. In some patients, even though we don't talk about cure, patients do expect gene therapy to give them curative levels of factor. In other words, levels that are normal or near normal. And of course, we would expect an annual cost saving on gene therapy, with the cost being invested upfront. Most patients believe that once they've had gene therapy, they can forget about the hemophilia treatment centers, which they have to visit throughout their lives because they need care as well as the replacement therapy that they are currently getting. Of course, those are some of the expectations of the patients, but what are the realities? Of course, we do expect that in the gene therapy to last long. We actually don't have data indicating how long it will last. We are concerned about the fact that the most vulnerable population, in other words, the pediatric population, has not yet been eligible for the current gene therapy programs. We are also concerned about the fact that the patients with pre-existing immunity to the adeno-associated virus are currently not eligible for the current gene therapy program. Of course, that will change over time. There is uncertainty about the durability and uncertainty about whether we can redose these patients in the event that the expression starts to go down. We do expect the gene therapy to have a high initial cost, and of course there are a large number of knowns and unknowns. Unknowns relating to the immunologic processes, the cellular stress, and of course whether or not over time we might see integration of the vector into the genome. We haven't seen that, in fact, in humans today. And perhaps to summarize, there are lots of knowns. We do know that, in fact, with the current gene therapies, we can achieve therapeutic factor levels in a fairly dose-dependent fashion. We do know that we can reduce or eliminate the need for exogenous clotting factor replacement. We can also manage transaminitis with steroids for those individuals who do develop transaminitis. And to date, we have not seen any patients developing inhibitors following successful expression of the factor. There are a lot more unknowns. We don't know if, in fact, gene therapy can be administered to patients that have got active infections such as HIV, hepatitis B, and hepatitis C. As indicated earlier on, we don't know if you can re-administer the gene therapy in patients who have had a failure of expression. We still have to find out if it is safe for the pediatric patients. And of course, the insertional mutagenesis is something that is at the back of our mind, but we don't know much about that. The durability of the expression, and of course, perhaps most importantly, the factors that are influencing the variable expression of the vector when the same dose is given to the patients. So in summary, in the context of the current gene therapy programs, I hope I have shown you that there are a number of studies that are underway. Some of them are past the proof of concept. Some of them have generated early safety and efficacy data, and some of them, in fact, have progressed to phase 3 studies. In terms of the safety, we would like to believe that safety will always be the number one consideration in gene therapy, and most of us are keeping a very, very close look at the safety aspect. To date, there are no safety profiles that are particularly worrying. Efficacy seems to be very promising as well. There is now patients that can have a durable expression, at least in the time period that we've observed them, and some of them have managed to come off completely of the replacement therapy. There are a couple of things that we don't know. We obviously still have to understand the immune response that some patients have. That analysis is underway, and hopefully over time we'll understand the reasons why some patients do develop transaminitis whilst others do not. Of course, we also need to keep in mind the balancing of the risk and the benefit at any given time. We do know that there are a number of aspects of gene therapy that we have a clear understanding on, but there are other aspects that we do not have a clear understanding on, and we hope that, in fact, over time, gene therapy, with the understanding of the knowns, will be able to improve the patient's life. It might be a while, of course, before the patients, other populations, including the pediatric populations, the adolescent populations, and the patients with pre-existing immunity, before they can take advantage of this amazing advance in therapeutics in hemophilia. Thank you for your attention.